So hopefully they will come in as we are going through the presentation. So really thank you all for joining us for this really important and timely discussion on WASH as a foundation of maternal newborn child health. I'm Elisha Dunn-Georgiou. I'm the president and CEO of Global Health Council, and I will be your moderator for today. Today's conversation is really about something quite simple, or at least should be simple, which is that you cannot deliver safe, quality care for women, newborns, and children without reliable water, sanitation, and hygiene. And we're really talking here about WASH not as an add-on, but as core health infrastructure and something that underpins everything from safe childbirth to infection prevention to basic dignity in care. This is a particularly timely discussion. We're coming to the end of March, which is both Women's History Month, and we just passed World Water Day. And we really thought it was important to take a moment to talk about this intersection of WASH and maternal health and newborn child health. It doesn't get talked about enough as far as GHC is concerned. And so wanted to pull together a session that really takes a moment to reflect where progress has been made and where very basic gaps still remain in too many health facilities. So we've put together an amazing panel for you, brings together a bunch of different perspectives from policy and evidence to frontline delivery and humanitarian settings to really understand how WASH shows up across the system and what it will take to more fully integrate it into how we think about investments in health and women and children. So can everyone who's not a panelist please mute themselves? Or Ansley, could you please mute? We want to make sure that we get to hear our panelists. And let me just say, we're happy to have such a strong panel with us today, and I'm just going to briefly introduce them. First, we have Elisha Schechtman, who's the founder and CEO of Egeria Strategies and former USAID person who worked on WASH. We also have Elizabeth Marcy, who's the managing director of policy and advocacy at WaterAid America. We have Nhlanhla Ncube, the environmental services and WASH manager from Partners in Health in Sierra Leone, and Mauricio Pérez, who is WASH technical expert with Project Hope in Venezuela. It should be a really interesting and rich panel and discussion. Before I turn it to Lisa to kick us off, just a few logistical notes. So this is set, as you can see, as a Zoom meeting, which means that audience can come off of mute. Please don't until we get to the Q&A section. But also we will definitely have a Q&A section for the audience. Each panelist is going to give some opening remarks to help set the scene. And then I'll ask a few moderator questions, and then we'll open up to the audience. As panelists are speaking, please feel free, if a question pops in your mind, to put it into the chat. And the meeting is also being recorded. We will share a recording following the session. And with that, I think we are good to get started. So I'm going to turn over to Elisha Schechtman to give us really a landscape setting about WASH as a health systems issue and sort of where WASH sits today within the greater health sphere. Over to you, Lisa.
Thanks, Elisha. And good morning, afternoon, evening, everyone. I will try to be as brief as I can because I think we need to save time for the actual examples from Venezuela and Sierra Leone that we're going to hear. And there's a lot that goes into WASH in health systems. There's multiple components of WASH. And I won't dive into them too deeply. If there's questions at the end, we can go through them. But next slide. I just wanted to start by giving a sense of the impact of low access to WASH. So this graph shows the global burden of mortality from the five leading wash-related causes. So diarrhea, acute respiratory infections, particularly pneumonia, soil transmitted helminths, which are otherwise known as intestinal worms, and undernutrition. Um, that is SDG indicator 3.9.2. So it inherently links SDG 3 to SDG 6. And you can see that there's a really strong and clear concentration of the dark purple colors across Central and Southern Africa in particular, and also in South Asia. Annually, there's 1.4 million deaths a year from those five causes directly linked to low access to wash. And just to illustrate that, 69% of deaths from diarrhea are related to poor access to safe drinking water, sanitation, or hygiene. And the majority of those are children under the age of 5. There's also about 360,000 deaths a year from acute respiratory infections that are directly because of poor hand hygiene. And that can be a lack of water, a lack of soap, or a lack of both. Next slide. This is a very quick overview, a little bit of shock and awe for those who haven't paid a lot of attention to this situation in healthcare facilities worldwide. So I think the most shocking number here is that 3 billion people use a healthcare facility that doesn't have a basic latrine. But you can see that for water and hand washing stations with soap, those numbers are also over 1 billion people. So we have to look at whether they have each of those three elements of wash separately. And as you can see, the numbers are not the same from one health facility to another. That totals a lot of people that are exposed to significant risk of infection in their health seeking activities. And that doesn't include all of the healthcare workers that are also exposed. And we'll talk more about that. Around the world, rural health facilities and primary healthcare facilities have the lowest access to wash in across the board. Hospitals and tertiary facilities, and those in urban areas are more likely to have access to wash. It's also significantly worse in fragile contexts. So, just to give an example, in fragile settings, only 19% of all healthcare facilities have a basic latrine, and less than half of healthcare facilities in fragile contexts have basic hygiene services. Next slide. So as Elisha alluded to, this is a really important quality of care issue and a really important infection prevention and control issue. And Liz is going to talk a little bit more in detail about the impact of this on women and children, particularly newborns. But I just wanted to give you a quick sense of some of the impacts. So I think you all may be familiar with the high burden of healthcare associated infections. So this is infections that you acquire in a healthcare facility. And it's very often because of poor hand washing behaviors. So at least 15% of all patients in low and middle income countries will acquire one of these infections while seeking healthcare. And the real challenge is that many of them are multi-drug resistant. So we also have a massive antimicrobial resistance challenge that is fueled by healthcare facilities not having WASH. For the purposes of a maternal and child health conversation, it's really important to talk about sepsis. Sepsis is the third leading cause of both maternal mortality and neonatal mortality, and it's significantly reduced with good hand washing. And overall, the data from WHO tell us that if we had good infection prevention and control, most of which is to do with WASH, we could reduce these healthcare acquired infections by at least 30%, and that protects both patients and healthcare workers. So the last thing that I wanted to talk about is on the next slide is kind of the broad framing of the policy and financing for Washington healthcare facilities. And there's a lot of words on here, and I'll run through them kind of quickly. But the main point is that while at the global level and many national governments as well, we acknowledge that SDG 6 and SDG 3 are codependent. And we have some policies from WHO, UN General Assembly resolutions, et cetera, that state this. WASH is very, very poorly integrated into most health systems. And it's partly driven by the traditional vertical streams of development versus global health. It's also perpetuated by the fact that WASH and health are often different ministries in a country. So you might have the water ministry, and then you have the health ministry that also does hygiene, but the roles and responsibilities are not always clear. And when that trickles down to the district and facility level, you have challenges like healthcare systems feeling that the water system is responsible for providing water in a health facility. And the water system says, no, actually, you have to pay your bill. You have problems like lack of training for cleaners about how to do good environmental cleaning, or lack of salary for them, adding on to job duties without paying them and training them accordingly. And the net impact is that these healthcare facilities are really unsafe. They are often so unappealing that it changes people's health-seeking behaviors. And they are often so unappealing that healthcare workers don't want to work there. So it becomes a really big challenge. And there's a lot of different ways to get at a better integrated process so that the health system is really taking responsibility for the wash in those facilities. But it requires a lot of coordination starting from the very top. So I will stop there and pass back to Elisha or over to Liz, and look forward to discussing afterwards.
Thanks so much, Lisa. That was a great overview, and lots of really thoughtful points there about the complexity of integrating WASH and in health facilities. Next, we're going to turn to Liz Marcy from WaterAid America to talk a little bit more in depth about some of their recent findings around the impact or lack of WASH on maternal and newborn child health outcomes. So, Liz, please, over to you. And I think Ansley is going to share your slides. Yep, here we go.
Beautiful. Thank you. And thank you for having me. Good morning, good evening. I wanted to just pause a bit. Lisa, that was a fantastic overview of kind of the global situation around WASH and health systems. What I'm going to be presenting is some new research from WaterAid that we actually just launched last week, which talks about the impact of WASH, particularly within delivery settings in health facilities or health centers, and some of the statistics that we found. This is looking back at available data, but then we also partnered with White Ribbon Alliance to interview over 1,800 women and health workers about their own experiences, and captured that data as well. So we'll move on to the next piece. My hope is to give a nice tangible example of how these two things intersect. So one of the headlines from our research is that in sub-Saharan Africa, roughly 76.1% of all births happen in healthcare facilities that have unsafe conditions because of the lack of basic running water, soap, or a single toilet. This is the 76% is just those three things, but to be clear, we looked at a number of factors, including clean water, basic sanitation, latrine, hand washing stations, but also environmental cleaning and waste management at those healthcare facilities. We also reviewed about 13 different policies at the national and subnational level for 13 different countries. And then our capture of data is also not just Sub-Saharan Africa, but includes Asian countries as well. So that's just a little bit of background on what we're doing. Next slide, please. Great. So for advocacy purposes, I think one thing that we see that is constantly catching people's attention is that on average, every 2 seconds, a woman is giving birth in a healthcare facility that doesn't have clean water, toilets, or hygiene. And the top findings for us were that 65% of births lacked proper cleaning. But by far the biggest standout across the board in every single country was the deep lack of sanitation, meaning mothers don't have a place to go to the bathroom. Many women talked about having to wait 20 to 30 women deep. There being shared facilities between health workers and patients having only one bathroom for an entire health facility, no place to clean up, those sorts of things. So the reality is that all of this does drive towards what Lisa was speaking to in terms of maternal sepsis. And we really focus on the maternal side. So I just want to be clear, these statistics don't necessarily, except for the one on this page, reflect the newborn impact. But in sub-Saharan Africa, we do have high rates of maternal sepsis, almost 150% or 150 times higher than in Western countries. It's about 144 times. And 1 in 9 births have a case of maternal sepsis. So overall, 1 million women and newborns every year die because of preventable infections that they acquired during childbirth. And those include babies and moms who were in health settings. Next slide, please. So our message in this is basically WASH is a foundation. It's a really simple, sometimes not too exciting, but absolutely imperative intervention. Our research found that if we were to provide WASH in all delivery rooms in middle income and low income countries, we would reduce both the infection rate of sepsis by 9.7 million and the death rate as well by 50%. So that's about half in both instances. We also found that treating sepsis is roughly double the cost of providing that universal access for WASH in healthcare facilities. So this isn't just about lives, this is also about the smart thing to do. And the last thing I want to leave you with, because I do want to make sure we have a lot of time to discuss, this isn't just about the impact on mothers and babies and their families. It is also a trickle-down impact on other health outcomes. So we have this wonderful midwife from Liberia, and she was talking about, look, it's not just a trade-off of is there water and what's the health outcome? It's what am I not doing while I'm looking for water? And particularly, she said there is a tie-in here of postpartum hemorrhage. If I'm looking for water and my patient is in trouble, I'm not there because I'm looking for water. And so what are the trade-offs for that? And again, as Lisa mentioned, it is a deterrent and it keeps people away, keeps women away from health centers to have babies. And for women in particular, it is not unusual that we see women carrying their own water to a health facility, even while heavily pregnant. So just a few of the human impacts. I wanted to clearly connect how WASH is impacting the maternal child health space, in particular the outcomes of mortality. Next slide, just quickly. So I just wanted to say thank you. We will have a robust discussion on this, but one of the things I did want to call out is that WaterAid has launched as of last week a new global campaign called Time to Deliver, which is about raising awareness around the issue of WASH in healthcare facilities, particularly in delivery rooms. And I've listed the countries that are going to be doing grassroots mobilization on this issue, including direct lobbying. So if there is an interest, we have tons of materials, videos. We have a full report. The Born Without Water report should be shared. It is in both French and in English, and a whole bunch of assets. So if you're interested in that, please feel free to contact me. And I know that Elisha we'll be sending around some links as well. So I'll pass it back to Elisha so that we can get to the meat of the discussion.
Thank you. Thank you, Liz. I put the link to both the Born Without Water report and the Time to Deliver campaign in the chat, but we will definitely send those out as well when we send the follow-up email with the recording. Well, thank you for that. That's pretty sobering, I would say. And again, really illustrates how what we consider a basic intervention of water and sanitation is uh, able to deliver such complex outcomes, or bad or good, depending on how the wash systems are deployed. So from Lisa and Liz, we heard kind of a more global view, and now we're going to get a little more country specific. So, Nhlanhla, can I ask you to share your experiences from the front line in Sierra Leone with how WASH and MNCH work together? Over to you.
Sure. Thank you, Elisha, and welcome to everybody. Good morning, good afternoon, and good evening. My name is Nhlanhla. I'm an environmental services and WASH manager with Partners in Health. Is the profile is quite unique. Partners in Health saw it important to integrate environmental services and WASH, realizing the importance of these two departments having to integrate. So we have this profile of environmental services and WASH in healthcare facilities. I work in government hospital in Kono district, Sierra Leone. In this facility, it has expanded and grown mainly because of security, mainly because of a maternal center of excellence that was established, that was opened on the 14th of April. We were having a maternity and newborn center which had only 48 beds. And now we have a staggering 120-bed maternal center of excellence. It also has a neonatal intensive care unit with about 30 cots for inborn and outborn as well, kangaroo care and mother's dormitory. That growth made us realize the importance of WASH, not just as an infrastructure issue, but WASH being a clinical care system. And without WASH and sanitation and reliable hygiene systems, safe child and birth simply cannot happen. Just like what Liz emphasized on her last slide, she was really actually summarizing the frontline experiences that we're having. So I was fortunate to join the institution when we were transitioning from the government hospital maternity department to this new maternal center of excellence, which is being really supported through the partnership with Partners in Health. But when we arrived, resources definitely were not available for environmental services and WASH. We had only, for example, if I'm going to talk about figures, the staff that was responsible for this big facility, we only had 23 staff. But at the moment, it has grown and increased up to 135 staff that we have recruited and working with. And why reliable WASH is essential for childbirth, if I may allude to that. Clean water underpins everything: hand hygiene, instrument processing, theater scrubbing, neonatal care, cleaning high-touch surfaces, and without it, the risks rise sharply. This is what I experienced when I firstly arrived in the institution. We did not have reliable water supply. Water was not being treated. We did not have a reliable supply chain of equipment and consumables that are required for us to run a reliable environmental services and WASH department. It affected safe surgery and emergency obstetric care. Even emergency C-sections could not happen we had to stop some of them because staff could not even basically scrub because reliable water was not available. Because of all this, patient dignity and experience was really affected. Women in labor deserve clean toilets, for instance. They deserve clean beds. They deserve safe delivery rooms, running water to wash after childbirth. And these were the experiences that we were having before we then had this expansion to the maternal center of excellence. So as a frontline worker, the realities for WASH, if I may just break down them into five points. We had labor and delivery delays. We had neonatal intensive care unit vulnerabilities, theater disruptions, and staff burnout. Even loss of community trust from the Kono community. The trust led to fear of delivering in our facility. And these failures are not abstract. They affect lives every day. They were affecting lives every day, if I may say it like that, because we are fortunate to be now to be housed in a maternal center of excellence, which I just alluded to. So what we did was to strengthen WASH as the backbone of care. So to confront these challenges, we launched a comprehensive WASH strengthening approach. We expanded the laundry, bringing industrial washing machines. We expanded the waste zone. We increased water filtration capacities and disinfection. We expanded and professionalized the workforce, improved cleaning systems and supplies. And funny enough, here in Sierra Leone, they have very robust, very good WASH guidelines, IPC guidelines, but they were all shelved. No one was using them. So I was also fortunate not to develop any SOPs. They already had them. But because of lack of funding, like what Lisa alluded to earlier, these documents are there, these policies are there, everything is there, but nobody is using them. So in terms of developing comprehensive SOPs, I was fortunate to just dust off a document from the shelf and start to implement it because they have robust systems already in terms of documentation. We also changed the culture. Cleaners and clinical teams usually don't collaborate. Cleaners are one of the least looked at people in the facility. When it comes to financing, staffing, they are at the lowest on the food chain. But we also managed to change that culture to have cleaners, environmental services agents collaborating with the clinical staff. We now have some systems like daily checklists, joint monitoring, reporting, joint reporting and response maintenance. And WASH moved from just being a support service to a patient safety system. So I think for now, Elisha, I think I can stop here so that we can have more discussions in the following segments of our discussion. I think for now I can stop here.
Thank you. That is great. And I actually have so many questions in my head about how that change happened. So we'll get to that. But thank you so much for that and for all the work that you're doing. Lastly, last but not least, we want to just take a look at a situation that makes this already complex situation even more complex, which is WASH and MNCH in humanitarian fragile settings. Lisa alluded to this in her overview, but we're very pleased to have Mauricio from Project Hope in Venezuela here with us today, who is going to talk a little bit more in depth about that topic. So I think Ansley is going to pull up your slides. Here we go. And Mauricio, I will turn the spotlight over to you. And you're still muted, Mauricio. There you go.
Okay, thank you very much, everyone. Well, thank you to Global Council for this invitation and all for being here today in this webinar. And after this impressive overview from Lisa and Elizabeth Nocle, I am really impressed about what he described, because this is the kinds of challenges that we faced in Venezuela, actually. So let me introduce myself. My name is Mauricio Pérez. I'm a civil engineer with experience in water and sanitation systems. I currently work with Proyecto Esperanza, which is an implementing partner of Project Hope in Venezuela. But I have also worked in Jamaica and in Haiti, and all of them can be considered as fragile humanitarian settings. And no matter the causes, they have something in common. Health systems operate under significant constraints. And in this kind of context, WASH becomes critical, including for maternal care and infection prevention. So, okay, I don't know how to.
No, Ansley
Okay.
can move the slides for you if you, yeah, just let her know.
Okay, Ansley. Okay, next slide, please, Ansley. I'm sorry. Okay, so in humanitarian settings and from a WASH perspective, healthcare face challenges in services. We often see intermittent or non-existent water supply, poor waste management, unreliable waste collection services, frequent power outages, making basic hygiene extremely difficult. In terms of supply, please, Ainsley, in terms of supplies, there are shortages of cleaning supplies. In terms of infrastructure, please, Ainsley, could you please? Okay, supplies. Okay. Okay, yeah. Well, in terms of infrastructure, they used to be highly deteriorated. And in terms of human resources, staff are under pressure, often undertrained, poorly paid, and with limited exposure to high quality standards. So the problem is it's not only infrastructure, it's the system. So how do we address these needs? This next slide, Ainsley. So to respond to this, here in Venezuela, we implement a comprehensive interventions. And let me briefly share a case from a health center in Venezuela that faced most of the issues that I mentioned in the last slide. So what we did in this health center, I mean, we started from the basics, functioning of hand washing stations, toilets, and sinks for cleaning and sterilization for instrumentals, sinks for mop cleanings and all the stuff. But we have to think beyond. We have to think about reducing dependence on public services. I think this is very, very important. So please, Ainsley, next. So what we did first, we improved an existing well. Why? Due to the absence of a water supply from public. We built a water treatment system, please, Ainsley. Next, we built a water treatment system to provide safe water and increase water storage capacity. Please, Ainsley. Next picture, please. Next picture. Again, I'm sorry to bother you. There's a lot of pictures, but we considered it was very useful to show something about what we have done in the health center. So we increased dramatically the waste storage capacity. We built this water sheds. Next picture, please. Next picture, Ainsley, please, if you don't mind. Ainsley, okay. So we'll build this incineration station. Why? Given the lack of waste collection services. And next slide, please. We built septic tank due to the absence of a sewage network. Next picture, please. Okay, next picture. Okay, that's the septic tank that we have to build. Next picture, please, Ainsley. These are the septic tank, the sewage network that we have to build. Please slide. Next picture. So we have installed solar panels due to the frequent power outages. Please. Okay, so all of this is to reduce dependence on public services. So, and we also, please, next picture, we also rehabilitated internal spaces. And this is not strictly wash, but we think it's essential to meet clinical standards and dignified care. As you see in the picture, there was a dressing room. Please, next picture. This next picture. Okay. So we have to dignify care. So we think it's very important to rehabilitate internal spaces. So let's continue. At the same time, please, next slide. Okay. So at the same time, we provided wash supplies for cleaning and disinfections. We conduct training in cleaning and disinfection as well. And we established IPC committees with regular follow-up. And next, please, Ainsley. And we also engage local authorities to restore services. Sometimes we are lucky, sometimes we are not, but building this relationship, it's critical. So again, what is our objective? To reduce dependence on public services, to ensure continuity of good practices over time, and build relationships with local actors and authorities. Please, next slide. So what about the exit strategy? This is something very important. So after all of these interventions, no, please, next slide, please. I think that's the last one. Okay, now next slide, please. Next. We have to go to the exit strategy and sustainability slide. Next. We already view all of this. I'm sorry, guys. Okay, that's the right slide. Okay, so after all of these interventions, we begin to see improvements, more patients, better services, stronger community engagement, and a point of pride. Monthly consultations in the health centers that I showed to you increased from 25 to 600 monthly. So it was an impressive number, and this is good, but it also creates new pressure, more demand, more maintenance, and a higher need for consistent applications of protocols. So, and this is where sustainability becomes critical. And our exit strategy focuses on ensuring the facility can operate independently as much as possible. So this includes, please, next, Ainsley. This includes ensuring ongoing follow-up and accountability in WASH and IPC until a culture of high standards becomes internalized. And this takes time. As I mentioned, adherence to protocols tends to degrade over time. So this follow-up is very, very important. So building local capacity for maintenance, this is a key factor. Providing tools, consumables, and training. Promoting ownership. Staff is high motivated when they can carry out repairs themselves in community, sometimes even mobilizing community resources and transferring responsibility to local actors, to the staff and local authorities. This is a key factor. So please, Ainsley, okay, next. So the goal is to lead capacity, not dependency. And living capacity improves the morale of staff, the community becomes more engaged, and this is something that we have seen in many of the health centers where we have implemented our programs. And that's it. I finished, and thank you very much for your attention.
Thank you so much, Mauricio. It's great to see another example. And obviously, a lot of work goes into these transformations. If people have questions, please feel free to put them in the chat, or you can raise your hand as you think of something. I'm just going to ask. I mean, I have a lot of questions after this. My main question is, why do we still have this problem when it is so clear what a difference WASH in health systems makes to improve health outcomes? That's a big existential question. I don't expect a solid response, but I mean, listening to all of the presentations, it does feel to me like we have a lot of opportunities here. I mean, obviously, a lot of challenges, but I would just love to hear from each of our panelists what you think can be done, what needs to be done, whether that's at a local level, at a regional level, a global level. I think most of the people on this call are likely advocates or, program implementers, and it's hard to see these statistics and not want to take some action. At least that's how Global Health Council operates. We like to take action. So we'll just love to hear from each of you quickly, sort of what your ideas are. Like, what's the thing that you've done that's made the most difference? What do you think needs to be done that could make the most difference? And then happy to answer it. Open the floor to audience members. So I don't know who wants to start off. Maybe I'll just go in order. Lisa, then
Sure.
order of presenters.
Um, I think I'll take your kind of last comment first in terms of what I've seen work. It's when health stakeholders lead. So, for example, thinking about USAID programs, there was a program some of you may know called Momentum, which was focused on health system strengthening. And that program took resources from the water budget within USAID and mingled it with global health funding, and then focused on a whole health systems approach that included WASH. And those were really impactful programs because it was health people speaking to health people, and consulting with WASH people. And that helps to break down some of the challenges of, one ministry versus another, or these questions of whose problem is this to solve. And so my response to your first question, Elisha, is we really need a lot more advocacy and demand for quality of care from global health and local health stakeholders. It's been, I think, very easy for these silos, these vertical approaches to be perpetuated. We see it in the US advocacy community, just like people see it elsewhere in struggles between their ministries or at the local level, district health officers versus district water authorities. And so I think that joined up demand is really important, but the more that the health voices are leading, I think the stronger the impact.
Thank you, Lisa. Liz, Maurizio, or Tlon, do you want to give an answer as well? Go ahead, Maurizio.
Yes, I would like to add, I mean, when we arrive at this kind of health centers, I mean, they're facing lots of problems, and sometimes it is a finance challenge. So I think maybe the budgets are very limited, and sometimes we have to set priorities, but I think strongly believe that we need to focus on engagement and ownership and local capacity. And I think this is a key factor of all of this.
Maurizio, maybe while you're here answering that question, there was a question in the chat about community engagement and how have either you or Tlon worked to involve the community from the beginning? Was there a process, research, focus groups? any kind of input as to what was needed, maybe particularly around dignity of care. I'm adding that last part of the question, but it would be interesting to hear how you engage the community outside of the health facility.
Well, I have a nice story. It was in this health center actually. When they knew we need to hire a contractor to build a well, to be a deep well, they were so motivated about what we were doing in the health center that the community itself said, we can do that. I mean, you don't have to hire somebody and waste your money. And so they using local techniques. They using like a little branch. They knew where the water was. I mean, it was a very nice kind of process, and so they actually did the job. I mean, we provided just some resources, some tools, but they did the job, and that was a first step to engage the community. I mean, they by themselves, they solved the water supply problem. So that's the point of entry. And after that, they started to engage with the health centers and with the implementation in the health center. So we always have to look the ways to engage community. I think this is a very important factor in all of this. And when community see that somebody is helping, that somebody is doing something, they feel more engaged. And I think that's something very important that we have to focus on too.
Thanks, Mauricio.
Yeah.
Let me just see if Liz or Tlantlan, if you want to come in here to the sort of initial question I asked, and then we can take Sharon's question. Sharon, I see your hand. I'll get to you in just a minute. But Liz, please go ahead.
Yeah, no, I so many questions and so many things that I could say. One, you cannot discount the behavior change component of this, both for health workers, cleaners. Each one of us touched in this in some way, but it is probably the most important thing to success. Otherwise, you will have stations that are not used, maintained, or supported within the facility. And you will have communities that is detrimental to trust at all levels, that there's something in this facility that even the staff won't use. That is a significant message to communities at a level that I don't think people appreciate. So that behavior change component around WASH, not just the hygiene component, but around the dignity component, around what's acceptable, what's not acceptable, how you will work together to fix those issues is a big piece of what WaterAid focuses on, not just is way beyond the taps, way beyond the taps. And that also goes into one of the pieces that was put into the chat, which is going to your question, like, why isn't this being fixed? Yes, we have a responsibility issue where whose job is it to do this? But even more so, we have a finger pointing issue of when something doesn't work. It is not their responsibility. And so one of the things that we have seen significant success in when doing these projects is having a 10-year operation and maintenance budgeting plan and repair plan. You do not wait until something breaks. You have to maintain it now. And what that means in practice is for WaterAid, we're training female mechanics and engineers because those are the people that are allowed into maternity wards. Men really, it is a difficult place for a lot of women and a lot of cultures to have a man in a space like that. So really like having the uptake of that facility and that service itself requires women in those spaces, another burden that women often have to carry. But there are these behavioral and social issues. This is not just an engineering problem. It is about people and not just about IPC and infection rates. It's really about how do you change and build trust in a system that makes it something that everyone has attachment to, that they care about. But the demand component is by far the biggest way we have seen political will be garnered is having multiple stakeholders across these sectors come together and say, this is not acceptable. And what are we going to do to fix it? So just to lean into Lisa's piece, we can talk about WASH all day, but I think until doctors, health workers, and the global health community understand and are willing to scream about it themselves, we're not going to get the level of effort or incentives needed to address it.
Yeah, thank you, Liz. And the behavior change piece is a terrific point to make. Some of the hardest stuff to get to overcome and change, obviously. Nhlanhla, I just want to give you an opportunity here if there's something you'd like to say before I move to Sharon's question. Please go ahead.
Okay, thank you. Yeah, like what Elisa is just alluded to, it's a multi-sector approach that is definitely required, especially when it comes to WASH. There's infrastructure which the community on itself cannot manage. It needs a municipality. It needs some high level of technical expertise to be involved in running WASH for an institution. For instance, like the facility that I'm working at the moment, we are now talking of an excess of 300 beds. That's more than 70,000 liters of water that is required to be pumped, treated, and distributed in the facility. So the community cannot be the custodian of such infrastructure because the magnitude of the resource that is required is quite huge. So it's a multi-sector approach that is definitely required. Interesting enough, we are celebrating Women Month. The Maternal Center of Excellence was built by women. It was built by women. Our partner came in, trained local women to build the Maternal Center of Excellence. In our environmental services department, we also integrating WASH and the environment. The communities brought different types of plants and grass that we planted. We have green areas in our facility because it is patient-centered. Women in labor can walk out of the labor ward and go out to a green area, which was planted and developed by women of Kono. So it's actually a multi-sector approach. The stones that were used to build the facility were from the community chiefs. The land where this facility was built was also from the community chiefs. Then the other layers, I think Lisa talked about it, it's about budgeting for WASH. Yeah? Budgeting for WASH, not budgeting for health only, but for WASH. That one, there's a big gap. There's a big gap. You come into an institution like a hospital, WASH is not funded. They just fund the clinical side. They just fund pharmacy, laboratory. WASH is somewhere there. It's in a gray area, if it's the correct terminology. Yes. So a multi-sector approach, bring in Ministry of Health, bring in the water department. What sort of department do we need and where should it fall in? Then we might have a sustainable approach to WASH in healthcare systems. Thank you.
Thank you, Nhlanhla. And the facility sounds amazing. You should send those women over here to the US to improve dignity of care in maternity wards because it's lacking.
Oh, yeah.
Sharon, thank you so much for your patience. Please go ahead with your question.
Thank you so much for this opportunity and great conversation so far. I don't know, we are in 2026 and I just feel like we keep having the same conversations over and over. There is really no reason why low middle income countries are still having this issue, but there's a lot of factors, there are a lot of issues unfortunately happening that I don't think people tend to realize. So I'm currently based in the US, but I was born and raised in Cameroon. So this topic is it's not very easy to really solve this. I don't know if there's an easy answer to this when it comes to this WASH topic, because one, I'm going to speak in specific to my country, Cameroon. So currently right now, there seems to be, I think from what I understand is boreholes. I don't know if you guys are familiar with boreholes. So I think that's a system that they're now using now to get reliable water. So now they're now digging boreholes in a lot of the communities now in Cameroon. So unfortunately, these boreholes are not cheap. It's extremely expensive, right? in order to build those boreholes so that health facilities can get this water, and even communities can also get constant running water. These things are not cheap, they're very expensive. Unfortunately, low middle income countries have been relying on foreign countries for funding. So our leaders, our African leaders, again, they have to come up with funding. They have to stop relying on foreign countries to fund their projects. Unfortunately, a lot of times fundings or the ideas, project ideas, especially when it comes to WASH, on paper, it looks good. But when it comes to executing these projects, they fail to execute the plan. So I'm not really sure what an easy answer is to this. And I have to reach out to the point of Elizabeth. She mentioned about behavioral change. Unfortunately, when it comes to public health, behavioral change remains a very huge challenge for us when it comes to behavior change. Because one, yes, a health facility might have running water, they might have the latrine or toilet, but guess what? Clients or visitors might be using those toilets, but guess what they're doing? They're not leaving it clean for the next person to come and use, right? These health facilities might have workers, but those workers are not cleaning the toilets properly. The workers are properly not being paid. So when you think about it, there's just so many factors there's just so many issues when it comes to this topic. So I'm not really sure what's an easy answer or how this can be fixed, to be honest.
Sure. We're almost at time. So I hear you. I agree. It's very complex. I don't think there is a magic one solution. And I mean, we are in 2026, and I think the world has changed dramatically too in terms of financing, right? Global health financing, local health financing have all been somewhat upended in the past year. So, we don't have all the answers, but hopefully from this conversation, there's some beginning to think of different ways to approach this problem, and we can have more of these discussions and certainly continue working on it as a collective group. I I do want to just give each of our speakers maybe 30 seconds for like one last word. And I know certainly we're at the hour, so if people need to drop off, we completely understand. There's never enough time for all of the rich discussion that we could be having. So let me go in reverse order here. Maurizio, do you have a one last word you'd like to say to everyone? No?
Well, responding to the comments of Sharon, I strongly believe in the ongoing follow-up and accountability in Washington IBC. As I mentioned, adherence to protocols tend to degrade over time, so follow-up is a very important factor until the culture of high standards becomes internalized. And this is something that very important, but this takes time. This takes time, but at the end, it's worth it. Okay. So, well, the goal is to lead capacity, not dependency. And that's my
Yeah, no, that's
closing
an
words.
excellent line and an excellent sentiment. So thank you for that. Nhlanhla, any last comment?
No, my last comment will be to thank you for having us on such a webinar where we are discussing WASH and health systems. I think it is important for us to continue advocating and talking about it, bringing it to this wider audience, bringing in clinical people, bringing in all stakeholders so that we start to talk about this and proffer solutions to it. So for me, it's just to say thank you for this opportunity and creating this this space for us.
Well, thank you so much for donating your time when you're doing very important work that we're taking you away from, but I'm really glad that you were able to be here for this discussion. Liz, and then one last comment from you, and then one last comment from Lisa, and we will close out.
Yeah, thanks. I think, look, the problem with WASH, whether it's in a healthcare facility, in a community setting, or in a water resource management piece, is it's never one thing. It's going to take a combination of a lot of things to fix it. which makes it inherently less exciting than a single dose vaccine, for example, which is where you get a lot of excitement because it's so easy to understand. It's just fixed. But we still have this problem because it's complex. It's not an easy answer. I really feel that. And the more that we are able to capture learning across sectors and build coalitions, partnerships, and joint momentum across sectors, the better the chance. I'm not saying it will fix it, but the better the chance we have that we are going to make sustainable impact. One of the biggest concerns I see is not just that, water ministers and health ministers aren't talking to each other, or that municipal budgets aren't integrated, or that national budgets don't fund WASH, even at the community level, let alone in health facilities. But even the advocates don't talk to each other. Even the policy experts don't talk to each other. But if you are in the field or you're a doctor, whether you're in the United States or in Sierra Leone, like everyone says, how am I supposed to do this if I can't even scrub? Like, exactly. It's not a point of contention for those on the front line. So it's also, I would say, a call to action for this community to talk to each other and to come together around this a little bit more. I don't think that it's going to be changed unless that happens. That would be my perspective.
Thanks, Liz. Thank you. And Lisa, 30 seconds.
Yeah, I can't say anything more compellingly than what the three people before me have said. And there's some really great comments in the chat. It really is about coming together and questioning and challenging the fact that decision makers, often including the heads of NGOs or the heads of hospitals, have had access to WASH for in some way for most of their life, and it's very easy to take it for granted. It's very easy to forget what it's like to have a pit latrine or to have to go collect water instead of going to school, or to go to a health facility that makes you feel sick just by walking in. And so we have to remember that we can't let people take it for granted. We can't let people get uncomfortable because talking about toilets is impolite. We have to really keep in mind that in many places, the elite might have forgotten. This is very true in the United States, what it's like to not have reliable wash, or what it's like to go to a clinic that doesn't feel safe. And so if we hold those examples in mind, we can slowly change hearts and minds together by saying, why are you taking this for granted? And hold governments accountable for the financing plans they have, for the budgets they've committed to, but we have to do it together.
Thank you so much. Lots of really rich words and advice, and all of those around accountability, capacity, not dependency, multi-sectoral, collective advocacy. So GHC will continue to work through those, and hopefully we'll have more convenings on WASH in health systems in the future. There's a lot more to say, and a lot more people to invite into the conversation. So thank you to our panelists. Really appreciate the amount of time you spent with us, and thank you to all of the participants. We will send a follow-up email with a recording, with some links, and please let's keep this conversation and action taking. Let's take some action going so that we can improve lives for the better. Thank you all. Hope everyone has a lovely rest of your day, and look forward to seeing you at other GHC events. Take care.